Sounds good. I went ahead and just started the recording.
Good morning, everyone. Thank you for joining us today. We're here to discuss corporate compliance and risk management. Not the most exciting or sexy topic to talk about, but also critically important for providers that are working in Medicaid and other third-party payer systems. This is brought to you by Hyde and Associates and Bernalillo County, our Department of Behavioral Health Services. So thank you for joining us today. My name is Sun Vega, and I have a background in healthcare operations. I was an executive for many years, and then I did consulting, and about 7 years ago, I started consulting, and my consulting work has been not only locally, but nationally as well. So I've had an opportunity to work with a lot of other, a myriad number of providers, including pharmaceutical companies, and all of that around the topic of behavioral health, and especially with Medicaid policy and programming. So thank you for joining us today. And I'd like to also pass it along to my colleague, Michael, who will introduce himself too. He's joining us and has supported this webinar as well. Oh, and Michelle too. I see Michelle joining us as well. So Michael, let's let Michelle introduce herself. I'm sorry.
Yep.
Hi, good morning. I've been on, I was struggling to get the sound on, but thank you everybody. I'm glad to be here. My name is Michelle Welby. I have worked most of my entire career on the industry side of managed care. Today I'm a consultant, and I work with several managed care clients in a variety of areas around Medicaid. And I have worked in the state in a previous capacity for the executive branch as Governor Richardson's health policy advisor. And I'm happy to be here to participate in this important topic. Thank you. Michael, I'll turn it over to you.
Very good. Good morning, everybody. I hope you're all hanging in there. My name is Michael Spanier. I have the esteemed honor and pleasure to work with Sun and Michelle as part of the Hyde and Associates team, and our leader, of course, is Pam Hyde. I have expertise in a couple of areas. Mostly I've done public sector and government consulting. I dove into that based on a 20+ year career in state government, mostly as both cabinet secretary and deputy cabinet secretary of the Aging and Long-Term Services Department, as well as the deputy state budget director at the Department of Finance. I have expertise in senior services. I've done a lot of work with New Mexico counties in the behavioral health arena, doing things such as strategic planning, needs assessment, gap analysis, that sort of thing. So that's a little about me, and I guess I can go on and talk about we have just a couple of virtual housekeeping issues to go over. Sun already mentioned, but I'll mention again in case other folks have just recently joined us, to please stay on mute, as well as turning off your video. That'll help us with the bandwidth, that sort of thing. These slides, these sessions, we're doing 4 of them. This is 3 out of 4. There'll be another this afternoon. Are being recorded, and they'll be available to you. They'll be accessible, I think, on the department's website. They can also be sent to you. I want to chat up, if you will, chat up the chat box. On this video conferencing platform, there's a chat box. We'd like for you to utilize that to ask questions throughout the presentation. We're going to try to move through without pausing for questions along the way. So please take advantage of the assets you have in Sun and Michelle. Please ask questions. It can be anonymously. If you want to follow up with questions, you can certainly do that through Jennifer and Raina as well. I think so. You may hear me say this again, maybe halfway through our presentation, to please utilize the expertise that you have access to at this point. And then, of course, at the end, we've allowed 2 hours, but chances are we won't need the entirety of the 2 hours. So you're certainly free to ask your questions at the end, time permitting. So with that, I'll hand it over to Sun to get us going.
Thank you, Michael. So our agenda today is, we've got some heavy lifting to do, and some of this stuff is not easy to really comprehend. So even for myself, it's taken me a few turns at even teaching on this topics, and so and I learn something new every time. So most certainly there are going to be questions, and everyone's situation around compliance and our regulatory environment is going to be very different. So keep in mind too that some of this is, I mean, in a lot of cases, it's not going to be one size fits all, but rather it's going to be how well can we make it fit. So with that being said, we're going to talk about the key laws and regulations that impact behavioral health providers. And what we'll do is we'll go through each of these key laws, highlighting kind of the major ones, and we'll talk about developing a compliance plan and some best practices around those. And then at the end, we'll talk about some of the learnings from the behavioral health shakeup. For those of you that aren't familiar with my background, I was the Chief Operating Officer for Team Builders Counseling Services back in 2013. And Team Builders was one of the organizations that was charged or had allegations of credible fraud, which were unfounded, and we were released from that. It was a terrible circumstance, but I think what I can at least provide is some learnings based on that experience, and help folks understand how that process even worked, because it's a mysterious process for many that's never undergone it, which I hope no one would ever have to experience that again. So let's begin with our kind of some structural things. So our federal body who oversees Medicaid and Medicare services, that's through the Department of Health and Human Services. And they have operating divisions as well as a separate Office of the Secretary. Now, the Office of the Secretary is what oversees a lot of the civil rights and anti-discrimination regulation, as well as the oversight of meeting our standards under Medicaid and Medicare. So those are the oversight bodies in our federal agency structure. We also have our state government. And so we have our three arms. We have the legislative, executive, and judicial. And the executive body maintains all our operating agencies under the governor's office. And we have the Human Services Department that maintains our medical assistance and behavioral health services divisions. And those are the key divisions that we operate under as providers when we're providing Medicaid services. Another office is the Attorney General's office in New Mexico. And our office here in New Mexico is fairly unique in some ways when you compare to other state attorneys general, because our Attorney General office is it's fairly independent. It's a elected office, so it's someone that's put in a position independently from the governor, and has some relative independence in terms of oversight in our state as well. And so they are responsible for the attorneys general for investigating and prosecuting fraud, particularly in the area of Medicaid. Our state Medicaid dollars, it's their responsibility to protect. And they also investigate abuse, neglect, and exploitation, in particular when we look at facility-based services. The New Mexico AG investigates several different types of fraud. It could range from just billing services that weren't provided in the first place to whistleblower actions. And whistleblower actions are basically private individuals that report some sort of malfeasance or suspect activity on behalf of the government. At the federal level, there's a tremendous attention under the Office of Inspector General to catch what they call now the most wanted fugitives. And this is literally the most recent list of fugitives that they've identified, our top 10 nationally, that have committed some kind of healthcare fraud in the United States. And they're after them. And it's a very serious allegation and charges that are being alleged against these individuals, and so we also have to be cognizant of keeping it, being serious about it too, because anyone that's doing any kind of criminal activity could be on that wall. So to bring it down a bit, I think there's some of the most recent cases involving false claims in New Mexico, and the most recent one happened back in April, where there was a settlement, and there's varying numbers of cases that are being investigated even today, but we don't often hear about them, and so this was a case of a New Mexico physician that was allegedly submitting claims that were for a procedure code that wasn't a part of a component of the service that was being provided by the physician. And so, and then additionally, it looks like that this physician allegedly had the same beneficiary for same dates of service. And so these are some of the red flags that come up as a part of these investigations. And what they had determined, at least the OIG, the federal agency, got involved and found that these bills shouldn't have been billed separately. And that's what we call unbundling. So it was an unauthorized unbundling, and it was not medically necessary. And so these claims were eventually settled. Another situation is where a federally qualified health center in New Mexico last year had entered into a settlement agreement with the OIG. This is at the federal level. And the allegation was based on some claims that were submitted under a grant. And so those of you that may not be familiar with FQHCs, they receive rural health center dollars, and those are grant funds typically. And they did something with their bills apparently that drew down some funds that were applied against some operating costs that weren't allowed under the grant. And so this is what the settlement outcome of that grant. So we just went through kind of a really broad scope of kind of who's out there, who's really charged with the responsibility of investigating and overseeing that our funds, our federal dollars, are being used prudently. And so let's talk a little bit more about the laws behind that impact behavioral health providers. I do want to provide this disclaimer that any of the information that's discussed today, it's not legal advice, so it's not intended to be that way. None of the content or materials are intended to be legal advice. And so if there's anything that that you believe you need some legal advice on, certainly contact an attorney and seek the appropriate counsel in your jurisdiction. And the views that are expressed here today are solely of the authors of this material and not those of Hyde and Associates in Bernalillo County. So our key federal laws that we're looking at today are identified here. We've got 6 of them in general. We have our Anti-Kickback Statute, the Stark Law. There's also a fairly new law called ECRA and a False Claims Act. And we also have the Patient Protection and Affordable Care Act, or the ACA. I have identified HIPAA and HITECH acts in here, but we won't be going into those in too much depth. The Anti-Kickback Statute is something that's been around for quite a while. It applies to all individuals and companies. So it's not just physicians, but individuals and provider organizations. And it basically makes it illegal to knowingly and willfully offer some kind of value. And it's not just money, but rather some kind of incentive to induce referrals to be generated for certain services under federal healthcare programs overall. There are some safe harbors that the Anti-Kickback Statute has for providers or physicians to basically allow some compensation arrangements, so to speak, that may seemingly offer remuneration for referral, but there's a mechanism in which, under these safe harbors, that those have to operate under. So it can be done, but it has to meet these safe harbor standards. So here gives you a sense of what those violations might look like under the Anti-Kickback Statute, like offering free services to encourage their use, or charging fees to participate in a different network, a more exclusive network. Offering free office space to physicians, or offering below market value to a provider for giving them offering administrative support, as an example. So these are just some examples. There's myriads of ways that these violations occur, and so we have to be careful about how we incentivize or compensate for certain services. This is a list of about the 10 provisions that are available under the safe harbor for anti-kickbacks. And so they're fairly extensive. There's several key items to meet under each of these 10 potential safe harbors for a provider and organization. And so these arrangements should be looked at closely. And I would certainly recommend inviting some expertise from a an attorney to assist with any of these provisions when you're working on such compensation arrangements. Under the Stark Law, so it's Stark Law and anti-kickback sometimes get a little bit, they get meshed together in folks' minds because they have very similar kind of purposes. But the Stark Law is different because it, from the Anti-Kickback Statute, because there are no safe harbors. And so basically, if you are, or if a physician in particular is doing self-referral for services that are under a some kind of suspect financial arrangement, there's liability. There's immediate liability. So unlike the anti-kickback statute, you don't need to knowingly or willfully do a self-referral. It could be even accidentally. And so we have to be very careful because there's a strict liability standard under Stark Law. And Stark Law applies to claims paid by Medicare and Medicaid, and it's only for designated health services. So we'll go over that. But anti-kickback statute covers all federally funded healthcare services and products. So anti-kickback is very broad, whereas Stark Law is very Medicare and Medicaid focused. Here are the designated health services I mentioned. And so these are the services that physicians are prohibited from ordering for Medicare and Medicaid patients when from an entity that maybe the physician had a family member of or some kind of other financial arrangement with. So they have to be very careful about how they provide services under this umbrella. And so some of those indicated here are like inpatient and outpatient hospital services, outpatient prescription drugs, prosthetics, things of that nature. And here's some examples of some self-referral violations. So let's take the first one here. Agreeing to engage in some kind of financial transaction with a physician practice, such as leasing space at a price below fair market value. And then at the same time, the physician's inducing, or the practice is inducing some kind of referral for patients from the physician as a result. Or referrals from one party that are using or leveraging a reward of referrals from the other party. And so that's any kind of referral arrangement like that is just not going to pass the standard here. Eliminating Kickbacks and Recovery Act, that is a fairly new statute that's been in place. It was effective back in October of 2018. And this law was enacted under the SUPPORT Act, or the Substance Use Disorder Prevention and that promotes Opioid Recovery and Treatment for Patients and Communities Act. That's a mouthful. So I'm glad there's an acronym for that. But this law basically was put in place as a result of over 70 bills that were combined together aimed to combat opioid and substance abuse crises across the nation. And the intention was to improve treatment and recovery options and increase education, prevention, and safeguard communities. And basically, this law is aimed at synthetic drugs, so opioids in particular. And what's occurred under this particular law is it basically prohibits referrals of substance abuse patients in exchange for some kind of kickback. And there's 3 different types of facilities that are targeted under this statute, and that's recovery homes, clinical treatment facilities, so that's a fairly broad category, and laboratories. And so the prohibition on referrals and for kickbacks from these types of facilities. And this is also broadly applied, not just through Medicare and Medicaid, but all federal and state funded services potentially. And so the language is so broad, and it's such a new law that the contours of it are still fairly new and unknown. And so there's not much in terms of common law or courts adjudications to give us all a better sense of how this is going to play out or shake out. The first enforcement activity that's happened actually just happened this year. It occurred in Kentucky, and it was a woman named, her last name Jackson, who admitted that she solicited kickbacks from a laboratory in exchange for drug testing referrals. And so she had lied also to law enforcement about this activity and about the kickbacks that she received. And she also attempted to cover it up by requesting the lab, actually calling the lab and asking the lab to alter its financial records. And so this office manager admitted to doing soliciting these kickbacks, and eventually was scheduled to be sentenced this May. So it happened just a week ago or so. And so she faced up to 20 years in prison and a maximum fine of $250,000. Now, keep in mind, though, these terms, the 20 years, is for all three charges. So it's not just the ECRA enforcement, but also lying to law enforcement and doing the cover-up. So that's what's wrapped up in all those years and the fine. So when we look at federal penalties, so we separate out anti-kickback, Stark, and ECRA. You'll see that anti-kickback fines are up to $25,000 and up to 5 years imprisonment, or both. Stark penalties, they range from it could be some takebacks, so recoupment activity from claims that were filed in violation of that law, or enforcing or directing a provider organization to refund those amounts. And then there's penalties. So the penalties can be fairly large because they stack up in terms of for each violation, and a provider or organization could be excluded from Medicare and Medicaid service. So it could be very steep, but well, there's really no buts. I mean, it is just steep, and the penalties, even on top of the each violation, there's also, if there's any kind of scheme, so whether it's some kind of complex scheme or conspiracy that's discovered, there's fines for that. And then there's also fines for failure to report. So if you are an individual that is aware of or know of certain circumstances that could be a violation under Stark, you could also face some kind of failure to report, and that could be a per day charge from the time that the person may have discovered that illicit activity. ECRA penalties, those bring down some criminal penalties related to this violation, and those may be up to 200 grand, and then you have imprisonment of not more than 10 years or both. So fairly steep penalties. So we have to be cognizant of these laws and follow through in terms of our own compliance planning and monitoring. What happened was HIPAA back in 1996 started to federalize healthcare crimes. And so we see from the time that HIPAA statute was put in place in 96, it evolved over time the fraud, waste, and abuse law construct. And so now we see that kind of progress through to 2013 under HIPAA and the final omnibus rule that was promulgated by the Department of Health and Human Services. And so this is something that's been evolving for many years. Of course, ECRA is now very new, and it takes into account more of the substance abuse treatment services. HIPAA is something that brought into play, everything that we as providers and healthcare services organizations know about and are familiar with, right? But sometimes we don't pay attention as much about the penalties about fraud. The titles under HIPAA provide a lot of protections for those dollars, those federal and state dollars, preventing against fraud, waste, and abuse. And so the thing that we are, talking about most are the guidelines governing health plans under HIPAA in particular. And that's what HIPAA's provisions were ultimately about, was easing the ability to make health information more portable, but also hold health insurance plans and providers more accountable under a national standard. HITECH, or Health Information Technology for Economic and Clinical Health, that act was promulgated a little later, and it was really signed into law back in 2009. And this law really took into account many of the factors that electronic health records, electronic exchange of information, transmission of that information was really strengthened. The enforcement was strengthened under HITECH. And so this law promoted the adoption and meaningful use standards under health information technology. So this law was what promulgated the incentive dollars for providers under Medicare or Medicaid to adopt a health information technology system. And it also, though, mandated some audits of covered agencies so that it strengthened a lot of the HIPAA privacy and security rules, and it established breach notification standards if there's ever a security breach. The False Claims Act, that is, it's an interesting law if you ever study it. It was something that was promulgated way back in the Civil War era under it's actually also in legal circles called the Lincoln Law, and because it was established back then when defense contractors were supplying the Army with boots and guns and artillery, and the quality of that munitions and even the bootstraps were so just in disrepair, so terrible that the soldiers couldn't even use it to fight the war. And they charged exorbitant prices under these contracts with the defense for defense. And so that's how this law became into being, the False Claims Act. And so the history starts back then, and it harks even back then when we even talk about the False Claims Act and any activity that may be suspect. And so the courts still look at that history. It's very interesting. But what it also does is it brings in the private individual who can sue, and those are called qui tams. And these are private parties that can blow the whistle on individuals or organizations that may be committing some kind of illicit activity under the False Claims Act. And what happens is that these key TAM individuals benefit from receiving 15 to 25% of whatever the recovery amount is. And so this is really a law that has upped the ante in terms of enforcement against healthcare providers, because there are now opportunities for other individuals outside of just being a provider or an enforcement agency, but rather private individuals that can blow the whistle and earn some kind of incentive based on any recovery that's made. And so, so there's a lot of, it's a very serious thing. And it's also something that we have, as providers, we have to pay attention to and be mindful of. So the most significant changes that were made to that Civil War era law was done back in 1986. And that was through the enactment of the FERA, or FERA. And that was the Fraud Enforcement Recovery Act. And it brought into this knowingly presenting false claims standard. And it's a standard that basically prohibits, if you know of submitting, making, or engaging, or even concealing any kind of false claim, you could be held liable under this law. And so it kind of rounds out even the willful nature. So if we are even doing it, because there's the standards level up from knowing to even willfully engaging, and so that's what it initially was the False Claims Act. It was a willing standard, but now it's knowing, and so it creates a little broader potential for improper well, we just have to avoid it. Then we have the Affordable Care Act, and that really included a number of other provisions, numerous provisions that upped the ante even more so with regard to new regulatory standards for program integrity. And so I know that we've heard that a lot, especially if you're working with third-party payers and with Medicaid or Medicare. Program integrity is a catchphrase, but it's also a legal term under the ACA. And so it really encourages providers to participate and to be cognizant of what they're doing under the law when they're furnishing services and billing claims. And I think what's also critical and part of our topic today, later in our discussion, is the establishment of a compliance program. And so what the ACA has done is it created the program integrity standards and the compliance programming requirements for Medicaid and Medicare providers. And most of these efforts were designed to reduce fraud, waste, and abuse. So the appropriations were increased to agencies like the OIG, like Health and Human Services, to incentivize states in particular as well to detect and catch fraud and waste. And so that's where the Medicaid program integrity comes into play. And then there's also RAC auditors, or recovery audit contractors, that are not only Medicare auditors, but they could also be used for Medicaid. The federal audit recoveries, if we look back through the past 2019 fiscal year, it's a revenue generating activity for the federal government. $5.9 billion were misspent under Medicare and Medicaid and other health and human services programs. And that's basically what was collected, $5.9 billion. And more than 819 of that was through audit, just simply through audit. And so when you look at these numbers, obviously the audits play a big deal, but investigations in terms of recoveries bring back $5 billion of those dollars. And criminal actions. So the OIG also brought in about 809 criminal actions, and these are actions that were out, substantiated claims for crimes against the program. And then there's also civil actions, which were basically like the settlement agreements that I mentioned in New Mexico earlier. So those were more of a civil action. And those were just lawsuits that were filed, and settlements were basically arranged. And I think the final thing related to these recoveries is the fact that individuals and entities get excluded from participation in Medicare, Medicaid, and other federal programs. So the exclusion part is pretty big because it could be, I believe the standard is up to about 10 years or more, maybe. I haven't looked into it recently, where an individual organization could be excluded from participating in these systems. Another part of the law that came down the pike was an act even back in 2005. And so in addition to the ACA in 2009, we also had the Federal Deficit Reduction Act. And this act had required entities that make or receive annual Medicaid payments of $5 million or more. So these are covered entities that make or receive $5 million or more in Medicaid payments are subject to this law. And so we already had some kind of standard to meet as providers to have policies in place about false claims and state laws about fraud, waste, and abuse. So there was it was a standard that existed, but the ACA basically bolstered. And so we have some familiarity around this, but the ACA really put it into enforcement. So what also happened under this act, the Deficit Reduction Act, was some standards related to states' involvement and making sure that there's that civil prosecutions happen, and that there not be there's really no requirement for proof of fraud, except that there's some kind of act of reckless disregard, as an example, or deliberate ignorance is another term that's used. And so when even though you may not have committed a knowing fraud or a willful fraud activity, if you just pretend like these rules don't apply to you, or don't seek additional training or technical assistance related to this, then and you could be committing it without knowingly doing it and still be subject to prosecution. So that's what this is about. So besides just the ACA, but there's also the DRA that kind of they're like bookends for the False Claims Act. Medicaid integrity programs were established under the DRA as well. And so this is what created the oversight from the OIG. And so the OIG was strengthened and bolstered as an agency to provide this oversight model for Medicare claims. And it was very ambitious at the time. Back in 2005, we were a bit in an economic slump. And so a lot of the incentives that were brought into play by Congress was basically to make to meet financial goals and to recoup and get paybacks for funds that were improperly used. There's also another section of the DRA with regard to third-party identification and payment, and this relates to states. And so, for example, the state of New Mexico, under this law, had to put into place some kind of third-party liability determination. So, self-insured health plans, pharmacy benefits, anyone that could be legally liable, there had to be some kind of standard put in place to establish liability under the law and for fraud, waste, and abuse activity. And so organizations were basically prohibited from taking a person's Medicaid status and under consideration as part of enrollment and making payments. So it was kind of interesting because it also broadened it beyond the Medicaid status as well. So the culmination of our Fraud Care Act, our the DRA, and then the ACA laws, I mean, those three laws really started just creating a whole wave of auditing activity and program integrity audits as well. And so, Medicare and Medicaid providers and organizations were really put into the microscope, and audits were just maybe as recent as the last 8 years ago, or maybe even 10, it could extend that far. The activity was fairly prevalent. And so, new auditors were being brought into the fray. Medicaid and Medicare organizations, not only federally, but the state, were hiring these auditors and doing what was prescribed under the law, and that was to recoup any overpayments, and a lot of tragic examples resulted, and that includes New Mexico. But there's also other states where even dentistry in Texas was hit tremendously as a result of RAC audits, and then in California and North Carolina as well. So, we as providers are not only subject to fraud, waste, and abuse law, to even just, put the straw on the, it's the last straw, I suppose, the camel's back almost. But we also have all these other compliance and audit risks to keep in mind. And it becomes very overwhelming. And understandably so, especially if you gain enough size and enough volume in terms of provision of Medicaid and Medicare services that your risk starts to increase a bit. And so, so these are the other aspects of compliance that we also have to keep in mind in addition to fraud, waste. So I'm going to just pause for a moment and just let everyone take a breath, because I know that was, it can be very confusing and overwhelming sometimes when we think about just the federal statutes that we may be subject to as providers in healthcare. And so it's just a matter of following and engaging in the compliance steps. And we'll talk about that toward a little later after this, after we talk about the state fraud laws. But there's some light at the tunnel, is what I'm saying. So these are the three major laws that are applied in our state, and And so these are enforced fairly regularly by our state agencies, and in particular our Attorney General office. And when we look at the New Mexico Medicaid Fraud Act, what it really does, it allows for civil and criminal enforcement for the AG to, and there's a department or a division in the Attorney General's office. It's a unit called the Medicaid Fraud Control Unit, or what they aptly nicknamed MFUCU. So if you ever hear MFUCU, that's what they're calling their Medicaid unit in the AG's office. And this office is charged with the ability to coordinate with the Human Services Department and with CYFD, the Children, Youth, and Families Department, and DOH, the Department of Health. And so there's a joint protocol that's in place amongst these agencies. And I also believe there's also aging and long-term care services as well. So this joint protocol establishes the responsibilities and procedures with the Attorney General in our state under this act. And what it does is it makes basically makes it under these remedies available for the AG to pursue and enforce any penalties. There's also the New Mexico Fraud Against Taxpayers Act. And this is what I would liken it to New Mexico's Whistleblower Act. It's a private qui tam action under the Taxpayers Act that allows private individuals to report suspected violations. And then what it also does, though, is allows the Attorney General to step in and intervene as a part of that lawsuit and file. The Medicaid False Claims Act, so it relates solely on Medicaid fraud, and it does allow qui tam lawsuits. And what it does, though, is it allows those lawsuits to be served on the Human Services Department, and then the Human Service Department would call on the AG to get involved if necessary. And this is a public disclosure law related to qui tam allegations, but it's a little different from the Taxpayer Act. And so here's a little grid to kind of demonstrate some of the key differences of those laws, because they do get confused and used interchangeably sometimes if you're not familiar enough with them. And so there's the False Claims Act, and then the Fraud Against Taxpayers Act. And so the types of claims are very different even as well. So when we talk about Medicaid, we're talking about healthcare services under the False Claims Act. And then the Fraud Against Taxpayers Act is more about money, property, and services that are provided or reimbursed by like a state agency. And then it identifies the folks, the parties that are involved under these laws. And so these are some of the key things to consider. And they can be used in tandem as a part of a charge. So being careful about your understanding of these and your obligations under these laws is important. The Medicaid Provider and Managed Care Act is a very new act that was effective this year. And this was a culmination of a lot of the hard work and advocacy of agency providers under Medicaid, but also, thankfully, Mary Kay Papin, our pro tem at the Senate, she really steadfastly held to development of this law and seeing it through. So thankfully, healthcare providers, we have this additional protection now, and it's been renamed. It was a former law that was modified and renamed as the Medicaid Provider Act. And what it does is it changes a lot of the ways that HSD would proceed to make any kind of allegation against a provider for allegedly committing some kind of fraud or seeking recoupment for Medicaid overpayments. So these are protections, and it also includes, which was a big deal for our managed care entities out there, it also includes MCOs as Medicaid providers under this act. And for many of us providers, we call it the due process law. We wish that this was in place many years ago, but we're so happy and fortunate to have it now. And it basically has codified a procedure for determining overpayments that was lacking in the past. And so now there's a methodology that allows not only, it's a transparent mechanism for providers and managed care entities, as well as the Human Service Department, to determine these overpayments or make any kind of allegation of fraud, a credible allegation of fraud. And so these key elements listed here are the protections that were put in place as a part of due process that wasn't existing. And I honestly, I would stress that any provider out there that is, doing Medicaid services and billing for it should be familiar with their rights and this statute, because it's going to be an important component of your own due process rights. So these are the additional elements, and just to highlight, I don't think I did this enough justice, is that what it did is it replaced a former New Mexico administrative code, and it replaced it with all these new provisions. And so there's now what didn't exist before, licensing and certification requirements for auditors, no extrapolation for certain findings, creating a right for a provider to have an informal conference, because those weren't allowed before, or even a right that was given. It also allows some flexibility for HSD to impose a corrective action plan, and then before even making any kind of final determination. So this slide, and I believe I have one more, that identifies all of the additional requirements that are available under this law. And I will tell you from personal experience, none of these additional requirements existed before, and that's why they are here now. And it's because that they needed to be in place to protect not only providers, but also our managed care entities, and give guidance to the Human Services Department. So let's talk about corporate compliance. I mentioned earlier that this is kind of the light of the tunnel. It's probably not quite as apt, but it's also something that gives providers and organizations something to sink their teeth into and to be able to take action on. And so compliance is particularly important for your agencies as you work in Medicaid and Medicare and other third parties payment. And so the key areas that you want to cover for your compliance programs is addressing billing and claims processing, your medical records documentation, how you credential and screen your staff, and how do you protect your consumers in terms of safety. And then if you're using an EHR, the security aspects around that. And some of the key things to consider as a part of your compliance checklist is just to kind of take a step back and look at these laws and regulations that I presented to you earlier today, and do they really impact my organization? Because perhaps they don't. And so you don't have to focus so much in those areas of law, but rather looking and keying in on those areas of risk that are pertinent to you as a behavioral health provider. And then, do you even have a formal compliance program in place? If you don't, now's a good time to start. And then how do you continue to evolve your compliance and your risk management so that your staff are trained and folks really this compliance becomes embedded as a part of your culture of your organization. A formal program is basically, if you think of it as a compliance program, it's just another management system. We have other management systems in place that for our services that we provide. And so it's another factor in terms of a line of programming that we have to keep in mind. But it's designed for preventing any violations or even detecting. So we want to be able to detect also and not only prevent. And this goes across the board, not only just employers or employees, but our officers and directors, any agents, even contractors that we work with need to comply with our corporate compliance program. And the goals behind them are fairly simple. It's just creating a system of controls in your organization and detecting, preventing, disseminating. So we're protecting a limited resource from fraud, waste, or abuse, and we're doing our best to detect any kind of misconduct or illegal activity. But we also want to make sure that everyone that is bought into this and assure that folks are aware that we need to abide by these laws, and it's a value that we adhere to in our agencies. And so what do you need? I've seen a myriad different types of compliance programs. And so these are not one size fits all factors. So depending on what your organization focuses on, whether it's maybe it's not Medicaid or Medicare, but it is federally funded programs, then there are components that we need to have in place to comply and assure that we're meeting these fraud, waste, and abuse standards. And so these are just an example of things that you could do and would potentially need as a part of that programming. This is a standard in terms of key elements that the Federal Office of Inspector General has put out as a guideline. And so these are the kind of the top 7 things that are important to comply with if you receive any kind of funding through the federal government, and to be prudent as well as the state. So these are things that you have to have in place. These are the key elements that you can't skimp on in terms of your compliance programming. So diving into each one of these elements. So let's written standards of conduct. We all must have some kind of written standard of conduct or requirement under some kind of standard for being honest and not committing any kind of fraud or abuse of our systems and programs. And so that's the first step. Secondarily is to have a compliance officer or even a committee responsible for implementation of your compliance program. And the compliance officer can take on many shapes or forms. It could be just an individual person on your management team that just, gosh, has a really good sense for detail and understanding rules and how to apply them, and can help with developing and implementing a program of this nature. And it also helps to have a committee, just because being a lone compliance officer, if he doesn't have enough bite or teeth in the program. And so having other management team members or the CEO or executive director involved as a part of that committee is also crucial to make sure that the enforcement aspect is adhered to as well. Training and education, gosh, I mean, these are so important. We're very familiar with how to train our staff in terms of HIPAA and complying with releasing information and those standards. And so I a lot of times I liken our compliance training as a way of just embedding that as a part of your other compliance factors that you have to consider when you're operating a program or services. And so how do you just kind of weave it into your initial trainings? How do you offer it annually as a refresher? And then focus on some key areas. If you have special documentation training or requirements that you do, maybe we weave in a little bit of compliance as a part of that as well. So it doesn't have to be a onerous process, but rather sprinkling it in to what you currently have and beefing up your cultural value around compliance in everything that you do. Auditing and evaluating your organization or your providers is also important. It's another mechanism of feedback that we all need to improve on our current systems and way we do things. And so auditing our records and that's part of the detection piece that we have to keep in mind. And so what the OIG has put down is that there's some minimum requirements for auditing and evaluation. And these are the 4 areas in which agencies and individual providers should keep in mind as you start doing your audit and evaluation for compliance. The internal reporting processes should also be in place, and this harks back to the whistleblower law and key TAM private individuals that can report on suspected activity that may be against the law. And so this is something that organizations have to have in place, is some kind of hotline or mechanism that employees can anonymously make reports. And also embedded as a part of that is, whether it's in your handbook or policy and procedures, a standard that states that no retaliatory action will be taken against an individual that reports. So these are also required components of your compliance programming. But in addition to that, to reporting, there's also punishment and some kind of disciplinary action. And so what do we have in place when we do discover or detect a misstep? How do we make sure that there's some kind of disciplinary action that's in place, so that it also becomes more preventative in nature as well, so it doesn't happen again? Investigating. So a part of the process of receiving anonymous reports from a potential private individual or employee is the ability to investigate and remediate issues. And so the compliance program has to take into consideration all right, so if there's a violation that's been reported, how do we investigate it? And how do we do it in a manner that's within a good standard timeline of addressing the issue that's at play? And if any laws have been broken, how do we report that appropriately? And so these are the things that we have to keep in mind as a part of our policy and procedure for investigating. And I recognize that as providers and even organizations, there's some budget costs related to maintaining a compliance program. And, you know, if it's a matter of initial program development, some of it has to be, you know, checking in with some kind of legal consultation to make sure that these laws that are presented here are applicable to our business and what we do in terms of provision of our healthcare services and what kind of funding we receive, whether it's federal or state, Medicaid or Medicare, and other grants. And so I think there's a lot of upfront potentially in terms of cost if we haven't engaged in that process before and getting some consulting support to make it happen. Because starting from zero is tough. But after you've developed your own internal expertise and training, and there's you know, we just keep in mind that, you know, if a law changes, obviously, or a new law comes down the pike, we might ask for more counsel. But then there's the ongoing training costs associated with that. But I think if we are mindful of how we embed compliance trainings and how our activity can be aligned with other things that we already do, I think we can minimize those costs. So compliance best practices, you know, ultimately what compliance does is it forces us to engage in a risk management process. And you know, it's not so much unlike when we look at market factors and how you know, the industry might be changing around us, or the state regulatory environment might be changing around us and impacts our business going forward. I mean, this is the same kind of engagement to that level of risk management where we are identifying, gosh, where are the areas that we're vulnerable? Where are the areas that we might be threatened in terms of our resources, and how can we control that? So engaging in that risk management mindset to reduce that risk, and it becomes a very invaluable component of the organization moving forward. So some key best practices, and you've heard me talk about culture and just embedding just a mindset of compliance on all levels of your organization, and using your audit practices and evaluation practice as a way to train staff and provide feedback, and then leveraging your EHR, if you have one, to do a lot of the reporting for you, so that it assists in your continuous compliance programming. And then just integrating that across the organization. So these are just some ways in which I would recommend embedding some compliance into your current training and your programming. You know, sometimes it's just a matter of adding one more annual program to your list of trainings as a topic, or you know, targeting that as compliance as a part of your supervision and training sessions that you have with staff. So ways that you can just embed that as a natural part of what you already do. And then centralizing it. So the idea behind having a compliance program also demands a little bit of centralized task. having someone, at least at some level, having oversight, and even with, releasing information and audit requests, it also really prevents duplication, especially if you're a high volume provider, having a centralized mechanism of managing that. Using technology, I cannot stress how EHR, if you don't already have one, will be a great benefit to your organization. I know that there's costs associated with that, but it also supports a lot of the risk management activities and oversight activities that you can do, especially from a centralized location. And so the ways that you can use an EHR, gosh, there's just, they abound. But here's just a few examples of how you can use an EHR, automate a lot of the way you do things in terms of coding and billing, and doing automated compliance through credentials and payer rules and things of that nature. And don't forget to update your compliance plans. I think what we fail to do sometimes is we work so hard to develop, whether it's a strategic plan or some kind of other big procedural and committee based plan, and we put it on a shelf and forget about it. But making sure that we comply with that plan and make updates with it on an annual basis at least, especially as new laws or regulations are passed. And then continuing to enhance it, whether it's use the tools that we created initially, just enhancing those tools as we move forward with our programming. So this is just a list of glossary of acronyms. In case we are operating in an environment where we speak in acronyms, but for those of us that aren't quite as familiar, I hope this is a useful tool for you. So on to the last topic, learnings from the New Mexico Behavioral Health Shakeup. You may have heard me say earlier that I was personally impacted by that as a leader in a fairly large children's behavioral health organization in the state. And I can tell you that we had a fairly strong compliance program. We did very well in terms of our audits and any kind of service reviews, certifications. We were on top of it, but nothing can prepare you for a potential allegation of fraud. And so I think that all the work that you put in yesterday will just be so fruitful for you for tomorrow. And so, this ounce of prevention is worth a pound of cure, I think says it. And, when you ever find yourself in a situation that may seem sticky or an allegation may have been made, seek legal counsel. I mean, that's the first thing you should do. And keep in mind that, as long as you've been working on your compliance program and crossing those T's and dotting those I's, have faith in what you've been doing, is what I've learned. Because we always, spend a lot of time second guessing ourselves too. And I think that if we just hold true to our value and our trust in the process of working through the compliance factors and following the law, then you'll come out okay on the other side. But I think that the big things that I've learned personally is documentation is so key. And I'm not speaking to like paper documentation. I'm talking about conversations that you have, key decisions that you make, standards or changes that you make in your organization and guidelines that you develop. making sure that you document those, and those are made clear and trained amongst your staff. And whenever you're under any kind of review or an audit process, keep a daily log of that. Just track the activity that's happening each day, who was present at what times of the day, and what was the outcome of each day, and having that timeline available to reference back to. And then knowing your service agreements is critical for any agency. If you're under any kind of particular pressure, those are, where your pressure points may lead you, and how you may need to address them as a part of your contractual agreements. So it's important to know those and have easy access to that information as leaders. And then again, I won't stress enough about having clear policy and training and procedures in place, particularly when it comes to the services that you provide, whether it's a Medicaid service or a Medicare service or some other third party or grant-based service. Understanding the level at which you should be providing those services and the requirements behind those. And then an EHR can be just a godsend. It'll save you tremendous amounts of time and effort, and storage, by the way. If you have paper, I would strongly encourage any provider that's still hanging on to paper to find a way to get rid of it. Because I think I've been buried in mountains of paper in the last 10 years or so. And, even though compliance programs aren't sexy or fun, when you meet an auditor or a law enforcement person at the door, they are just critical to your ongoing survival and engagement. So those are the key things I think that were kind of brought to mind and relevant to today's topic. I'd like to go ahead and just open up the floor to any questions or comments, even discussion, thoughts that may have sprung to mind from folks. And please unmute yourself if you want to talk. And we'll check our chat box to see if there's anything there.
Sun, this is Raina. Just kind of a thought that came to mind as you were discussing these things, especially about the functions of risk management kind of incurring some of those costs, which can be significant, right? So audits definitely are pretty costly in those items. And so, I started to think about how resourceful nonprofits can be, right? And I know we're not just only speaking to nonprofits, but in finding ways to pay for things. So a lot of that stuff, for instance, like legal advice, that can be embedded in some bylaws that kind of really influence board selection. Like, how do you maximize the resources that you have at hand? Also things like, even though paying for, it might be difficult to pay for the cost of a compliance kind of program, right? But on the other end of that, it might also potentially increase your eligibility for funding, right? And so looking on the other end of what the benefits of incurring those costs might be worth considering, especially when you're looking at that bill.
Well, I'm glad you said that, Raina, because I think that's something that we don't often anticipate, is that all the hard work and investment that you put into something will bear fruit in other ways too. And especially if you not just focus on compliance in a vacuum, but rather how it will really engage you in a different kind of process and worldview of how you're operating and managing risk in different ways. I think that having some kind of risk management programming is particularly important even when we're talking about safety of our own clients and families that we're working with. So embedding these steps into what you already do to comply with current laws and standards that you need to meet, I think is the first step. And then how do you turn it up a notch to really redefine how you do your programs and services and operations, and then maybe engage in right, like Raina mentioned, engaging in other ways to get funding. And so, yeah, I think that's a key thing to consider, is that doing compliance doesn't have to be in a vacuum.
Son, this is Michael.
Hi, Michael.
Hey, we have a question through the chat, so I'm just gonna let you know what the question is. What licenses are auditors required to have under the Medicaid Provider Act?
So I don't believe that the Act actually specifies a particular type of license or certification. But I haven't dove into the particulars of the code. But in general, if we look at NCQA as a standard or a benchmark for certification, and that's a national accreditation body used to certify auditors. And so that's a standard that's out there. There's other kind of accreditation bodies that are significant in healthcare and behavioral health in terms of an audit. So I personally don't know exactly what that is. That's a really good question. But I know that those are usually a national certification or standard, not so much a state-based certification that I know of. Good question. Any other thoughts, or and I'm happy to even talk about my own experience. So if you have questions about, gosh, how'd you survive? I'm happy to even talk about that.
Just another question through the through the chat box. The question is, how did you survive? And so I was kind of thinking along those same lines, right? How do you come back? How do you repair your reputation after that?
I'm sorry, I didn't catch the second part.
Just kind of my own kind of add to that. Just, what are some of the things you did to repair your reputation following that? Because I know that can look poor, right? Right.
Well, I will tell you that it was if anyone's ever experienced grief, that was basically the process that I had to undergo, because I worked for Team Builders counseling services for many years, and I sat at every chair and helped. I was a receptionist for a little while. I was doing records management. So I grew up in that agency and in behavioral health in terms of my own professional career, and so it was very disheartening. It it felt cruel. It felt it was a tremendous loss in terms of losing my work family, but also being under the gun, so to speak, in terms of having to undergo a very seemingly divisive process and engaging in a very intense audit. So the initial audit that came about, that was ordered by the Human Service Department at the time, was a surprise audit. They hired these auditors that were out of North Carolina, and it was a company It was actually a company that was more of an accounting audit firm. And so hence the reason why there's a requirement now for auditors to be certified. And so this firm showed up at our doorstep, and Team Builders at the time was in 24 counties. And so we had auditors show up at almost each of our offices on the same day. And imagine the surprise, but we engaged in that process. We engaged in the audit process, and we believed that it was a fair-minded and a good faith effort on our part to meet the requirements under that audit. But we didn't know at the time that there were other undercurrents and reasoning behind those audits. And for those of you that aren't familiar, there were 14 other providers that had to engage in this. And as a result of these audits, we were all accused of credible allegations of fraud. And so, as a result of that, we were turned over to the Office of the Attorney General, and we were basically under criminal investigation. And that's just the blunt truth of it. And I think we had a lot of faith in our systems, and we held to that, and we had a lot of faith in the people that are continued to be our friends and believers in our organizations, because we were all very well-established organizations. And I think that you just have to continue through the process and just complete the next step. And so that's how you kind of keep it in perspective and survive, is just to keep on looking to the next step and complete that next step and engage in that process and cross that bridge when you get there. And so we mobilized, and unfortunately we had to close our business. But I also and many others of my colleagues, we had to reinvent ourselves. And so that's why I even went on and did some consulting work. So I think that it's embracing the change and believing in yourself. There was a lot of doubt. Our reputations were most certainly dredged through the newspapers. We were accused of being criminals, but we knew otherwise. And we also had a lot of support. I think everyone else in the behavioral health community at the time believed how much of a sham it was, and so we held true to that, our faith in that, and knowing that what we did was right. And we were all exonerated by the Attorney General. And in fact, I engaged in a summer program. I'm in law school. I'm actually just graduating, and I went to work for the Attorney General, who hired me, and talk about full circle and validation in terms of my ability. But the same Mofuku unit that investigated us hired me and allowed me to work there for the summer, and I got to learn a lot from them through that process as well. So I think it's just evolution that we have to embrace and move into.
Son, there's a follow-up question on that, and then we have one additional question after that on a separate issue. The follow-up question is, what do you think has been the lasting damage to clients today as a result of that shakeup?
Well, I think there are many levels of damage. There were a lot of families that couldn't re-engage in services, a lot of adults out there that were engaged in services experiencing SMI that we've lost. I think that's one of the things that has been a true injustice is the fact that people that we were serving and helping and really, shedding, bringing them out into the light, so to speak, are now in darkness because they lost trust in the system. And so we basically have to rebuild that system of trust. And that's not only applies to our clients and families, but also providers out there that witnessed some of this really tragic circumstances. And there's a lot of people that remain standing, even though the 15 providers were hit pretty hard. A handful were able to continue on and survive, but they also had to bear a significant burden in terms of what was remaining and to be able to shore up a safety net and services. And so I think as a community, we have a lot of work to do still to rebuild. But I think, that's one of the significant losses in terms of re-engaging people back into a system of care. And then, the losses we had children, teens that we worked with that committed suicide because they were no longer engaged in services. So we can never bring back those losses. But I think we just have to learn from this and keep this in our institutional memory. And I think that sometimes that gets, it's surprising to me that time's passed so quickly and we're almost, 10 years out. And the institutional memory is starting to fade, but I think it's important that we hang on to it a bit and learn from it going forward.
Hi, Sun. This is Michelle. I would also say the ripple effect was so profound. So even in terms of the MCOs, so speaking personally, I was at Molina at the time and then consulting for them. So before Centennial Care was rolled up into the 3 MCOs that also handle behavioral health, there was only one behavioral health MCO. And so the other MCOs were scratching their heads saying, if there's going to be an audit of behavioral health providers, the audit should have been with those folks accepting the claims. And so that was a big effect. Or a big mystery. And then when Centennial Care started, and in 2.0 now the behavioral health is underneath that, there's a large suspicion on behalf of the behavioral health providers about how they contract, with whom they contract. Sometimes you hear statements, we have no choice, we have to take these contracts, but how does your claims auditing systems work? What are we responsible for? There's a lot of education. With providers, I would say just this profound ripple effect of suspicion of dealing with some aspects of Medicaid again. Then I would also add that, where do the MCOs put all of their compliance requirements for you as a provider? Those are in your provider manuals. A lot of things are stuffed in those manuals. They're several hundred pages long. And the reason that insurance companies do that is they don't want to recontract with everybody every year if a regulation changes. So you have a couple of lines in your contract that say, you must also adhere to the policy and procedures of the provider manual. So don't forget about those in your compliance program either. I'm saying that as an aside, but getting back to the ripple effect, again, I talked to a lot of behavioral health providers, helping them contract with another insurance agency, and the specificity, that some of them are asking for, I want to know exactly how much I'm going to be paid. And in fact, I'm only going to bill under these few codes. and we're going to know these codes intimately, because I never want to go through what anybody went through previously. So I think the effects have been profound, even if they, as you said, it's in the institutional memory. It's sort of like the historical trauma of behavioral health providers. So
right.
that's my 2 cents.
Thank you.
Another.
Oh, sorry. Go ahead, Michael.
I was just going to say another question that we have is, how do you recommend addressing disagreements on coding rules between the finance staff versus clinicians when they have very different perspectives on how a code should be used?
Well, I think you first go to the source of truth in terms of the code and the service and how it's regulated. And so that source of truth often is the American Medical Association description. If you don't have a coding manual, a behavioral health coding manual, I strongly recommend that you get one because they're super helpful. And I would imagine that it would provide a lot of insight for not only the finance department, but also clinicians in regard to how certain codes should be managed and billed. So that's the first source of truth. But if it still continues to be vague, then I would, do a little research. But then at the same time, I also would err on the side of being fiscally prudent and putting your risk management hat on and making a determination in your own organization of what kind of risk you're willing to take as related to that service or that code. So that would be my quick pitch on that.
Another question is, how do you recommend finding good legal counsel? And do you have any recommendations about walking down that road?
There's a lot of good counsel. And we're lucky because we have a legal a law school institute that pumps out a lot of good lawyers. And so in terms of finding legal counsel, I can't provide a specific referral, but I can give you offline some information about some attorneys and organizations that have healthcare lawyers on their teams that I'm happy to provide. The other place, and anyone can do this, is call your state bar. No one ever really thinks about this, but you can actually call your New Mexico State Bar and ask for a listing of lawyers, and perhaps some of those lawyers may have a specialty or of healthcare listed with them. So that's a approach anyone can do. All right. Any other questions or thoughts?
Hi, son.
Yeah.
This is Michelle. I'd like to go back to that previous question about addressing a disagreement between a clinician and somebody else. You can always go to payer sources too. So Presbyterian, Blue Cross, Western Sky. A Presbyterian has a lot of experience. They're the only MCO that has been with Medicaid since the inception. They have a real robust behavioral health department and a lot of knowledgeable provider reps. But, you could call your provider services rep of any of them, whether it's about Medicare, Medicaid, or commercial, and say, we want to make sure we're billing appropriately. Let me get this understanding. And of course, there may be different rates by different providers and degree, but But as Sun said, you go to the manual, you look up the code, and then you can ask them, are you seeing any billing problems with this in general for your book of business? Are there things that we need to know? Is there documentation required that we need to be aware of? You know, what's your experience? We want to make sure we're doing things correctly. So they're a huge resource for you on billing because they're the ones paying the claims and they want to ensure that they're paying you appropriately. So you might want to use them as sort of the decision maker as well, or at least some input for that.
And I'd like to preface that too. I think that's good feedback, but I also understand that there's a relative fear in approaching a payer source about a question of that nature. And so oftentimes what I've done in the past is use a more public forum for that kind of discussion, in particular when there's a number of providers that are in the same boat. You know, a provider association is a great way to launch questions of that nature potentially. So if you're not a part of a provider association, I would encourage that you do so, or even just even loosely organize again with other providers that may be dealing with the same issue, and try to advocate for each other in that way. All right. Well, thank you so much, everyone. Excellent questions and comments. I appreciate everyone's attendance today. And for those that were unable to participate, this will be available. It's been recorded and will be made available on the Bernalillo County website. And I'm sure everyone will receive notice of that once that's been done. But otherwise, I'm also happy to engage and continue to engage in this discussion via email if you have other thoughts or questions related to our webinar today. So, and thanks to Michelle and Michael and the team, Jennifer and Raina at DBHS for having us.
Son,
Absolutely fun. Thank you.
Son, I just had one quick question regarding attendance. There's a couple of numbers on the list, and I just wanted to see if you're willing to tell me who you are and what agency you're with, so we get a good list of attendance on this end. The first number is 225-6023.
All right. And you have my email too, so if you know who you are, you can just send me your name and that associated with that number. We'll make sure we get you on that list. Thank you all very much. Take care.
Thanks. Bye-bye.
Thank you.
Stop recording.